Hey guys, it's Medicosis Perfectionalis, where medicine makes perfect sense. Let's continue our physiology playlist. In previous videos, we talked about motility and secretions of the stomach and the intestine. We talked about the enteric nervous system. We talked about the pancreas, the liver, and the bile. Today, it's time for bilirubin and what happens when the serum total bilirubin exceeds 2 milligrams per deciliter. It's a condition known as jaundice, where you get yellowish discoloration of the skin, mucous membrane, and the sclera. Let's get started.
But hey, Medicosis, why did we call it bilirubin?
Bili because it's in the bile. Rubra means red, referring to the red blood cell. And anything that's related to proteins usually ends in IN. Please watch the videos in my physiology playlist in order. The liver has many functions: metabolism, detoxification, synthesis of plasma proteins, etc. It's not just plasma proteins. Remember, during embryology, your liver used to make red blood cells.
Alright, but I am an adult now. What will the liver do to my red blood cells?
Well, the liver will take care of the waste product of the red blood cells. First, the anatomy. Here is your lovely liver, right versus left lobe. Right hepatic duct from the right lobe, left hepatic duct from the left lobe. They will join together to make a common hepatic duct. Then the common hepatic duct will join the cystic duct, which is coming from the gallbladder or the cholecyst. And then common hepatic plus cystic duct equals common bile duct or CBD. Although Joe Rogan will have a different understanding of this acronym. Then the common bile duct and the main pancreatic duct will open together here at the ampulla of Vata into the posteromedial aspect of the second part of the duodenum.
But hey, Medicosis, what's the color of bilirubin?
It's a greenish yellow pigment. And by the way, if you perform fresh dissection or if you perform surgery, you might find that the intestine is stained with a greenish yellow pigment. What's that? It's bilirubin. Who made it? The liver. Who stored it? The gallbladder. Your liver is amazing. It will make some good stuff for you and it will help you get rid of the bad stuff. What's the good stuff? Bile acids and bile salts. What is the bad stuff? Bilirubin.
Why are bile acids and bile salts good?
Because they help you emulsify and therefore digest and therefore absorb lipids. They can also help get rid of some of the excess cholesterol that you may have.
And why is bilirubin bad?
Because it's a waste product of red blood cell destruction. Your liver makes bile. Bile could be referred to as chole. Why do we call it chole? Because it's made of cholesterol. Here is cholesterol. The bile acids are also made of cholesterol. So in the bile that's made in the liver and stored in the gallbladder, you'll find the good stuff and the bad stuff. The good stuff in the bile and the good stuff from the pancreas will help you digest and emulsify fat. Please refer to the previous video to learn more. As for today, we're talking about the bad stuff, bilirubin. Let me digress for a second and remind you of the topic of drug metabolism. When you take a medication, 4 things will happen. First, you will absorb it, then you will distribute it all over the body, then you will metabolize it in the liver, usually transforming it from active to inactive, and then, after all, you gotta get rid of it, excretion. Let's talk more about metabolism. Who is the hero of metabolism? The liver is. And metabolism will take place in 2 phases. Phase 1, modification, and phase 2, conjugation.
What do you mean by modification?
Oxidation, reduction, or hydrolysis.
What do you mean by conjugation?
It could be acetylation or methylation or glutathione or glucouronidation or sulfation.
But hey, Medicosis, what does the word conjugation mean?
It means to conjugate.
Oh, that was not so helpful.
It means to join together. You can join me with an acetyl group. You can join me with a methyl group. You can join me with glucouronidil. And this will be the story of bilirubin. If you recall the previous video, bile acids were conjugated to give you bile salts. Bile acids were conjugated to give you bile salts. So the definition of bile salts is conjugated bile acids. What are the bile acids? Cholic acid and chenodeoxycholic acid. And then you conjugate them, i.e. you join them with glycine or taurine to give you bile salts. Conjugation means to join. The same thing will happen to bilirubin. Just watch. What is bilirubin? It's the waste product of red blood cell. I don't get it. Well, your red blood cells should last you about 120 days. This is their natural lifespan. After this, they get old and senescent. They are unable to function properly, and that's why your spleen will get rid of them. Hashtag splenic macrophages. Once your macrophages destroy your own senescent blood cells, the red blood cells will release what was in them. Who was that? Hemoglobin. Hemoglobin is made of what? Well, heme and globin.
Okay, medicosis, so my spleen is destroying the red blood cells, releasing hemoglobin. And hemoglobin is made of heme and globin.
Yes, heme is made of iron and protoporphyrin. Protoporphyrin will become biliverdin. We are opening it up. We are breaking it down. We are exposing it. We are catabolizing it. So protoporphyrin, biliverdin, verd means green. That's why this is a greenish yellowish pigment. In different languages, verd or vert means green. And then you give me bilirubin. It's the result of destruction of red blood cells, and you will find it in the bile. So far, this bilirubin came from the red blood cells, from the blood. So we call it heme bilirubin. So far, we haven't conjugated anything yet, so we call it unconjugated. If you do the Vandenberg test in the lab, it will give you indirect Vandenberg test. This bilirubin before conjugation is still fat soluble. It cannot float freely in your bloodstream because your blood is water soluble. Your blood is basically water plus some plasma proteins, plus some blood cells. So, since it's fat soluble, it cannot float in the blood, therefore we have to carry it on albumin, because water and oil don't mix. All of this happened before we reach the liver. Once we reach the liver, 4 things will happen. Number 1, active uptake. Number 2, binding with cytoplasmic proteins. Number 3, conjugation with glucouronic acid, thanks to the enzyme UDP glucouronidyl transferase. Goodness gracious. And then number 4 is excretion of this conjugated bilirubin into the bile, into the duodenum, particularly the posteromedial aspect of the second part of the duodenum. After you conjugated the bilirubin, we will call it conjugated bilirubin. Since it's in the bile now, we call it cholebilirubin. The whole purpose of conjugation is to change the bilirubin from fat-soluble to water-soluble so that the kidney can excrete it because it's waste. Which means this conjugated bilirubin is water-soluble, and it will give you that direct Vandenberg test in biochemistry.
What should I do with this conjugated bilirubin?
Excrete it into the intestine.
What's going to happen to the intestine?
The intestine is full of bacteria. The bacteria will convert bilirubin to bilinogen. This bilinogen eventually will end up in the urine. We call it urobilinogen. But urobilinogen is not active yet. It will be activated to urobilin.
Okay, medicosis, is this the only way to get rid of this waste?
No, it's not the only one. Far from it. This bilinogen can end up in the stool as well. We call it stercobilinogen in the stool, and then it will become stercobilin, which is active, and this is responsible for the normal brown color of your stool.
Alright, medicosis, I get it. Anything else?
Yeah, some of that wasteful urobilinogen will sneak back to the liver via the intrahepatic circulation. So the intrahepatic circulation will return to the liver some good stuff, bile salts, and some bad stuff, urobilinogen. And the liver will get rid of it again, and eventually it will reach the urine. So, to recap, you destroy your senescent red blood cells releasing hemoglobin, which is made of heme and globin. Heme is made of iron and protoporphyrin. Protoporphyrin will become biliverdin. Biliverdin will become bilirubin. So far, it is unconjugated, indirect heme bilirubin. Then the liver will uptake it, bind it, conjugate it with glucouronic acid thanks to UDP glucouronidyl transferase enzyme. Now the bilirubin has become conjugated cholebilirubin, which is water-soluble and will give you direct Vandenberg test. So the unconjugated bilirubin is indirect, but the conjugated is direct. Let's excrete this conjugated bilirubin into the intestine, and now we'll have another transformation from bilirubin to bilinogen. In the urine, uro. In the stool, sterco.
Okay, medicosis, but let me ask you a question. What if I have an obstruction of the biliary system? What do you think is going to happen?
The conjugated bilirubin will be unable to reach the intestine. It will have to go somewhere else. It will leak to the blood because the liver is heavily vascular. And now the liver will dump two things into the blood: the good stuff, bile salts, and the bad stuff, conjugated bilirubin. And these two doofuses go hand in hand. Whenever the patient has elevated level of conjugate bilirubin, you can bet the rent money that the bile salts are also high. So here is a cool bilirubin mnemonic from a famous Egyptian professor. Look, everything here is 2. How many stories do I need to hear? 2 stories. The story of bilirubin and the story of bilinogen. Each type has 2 subtypes. The bilirubin is either heme or chole. The bilinogen is either uro or sterco. The heme bilirubin is the same as unconjugate bilirubin, which will give you the indirect Vandenberg test, and it's lipid soluble. The whole purpose of conjugation is to convert from lipid soluble into water soluble so that we can dump it in the kidney. Because if you're lipid soluble, it will be very unlikely that you will end up in the urine, because remember, if you're fat soluble, you are bind to albumin. And albumin is too big to be filtered in the glomerulus. That's why you need to conjugate the waste in order to be able to get rid of it. See, medicine makes so much sense once you understand what the flip you're talking about.
Okay, medicosis, now let's conjugate. Who will conjugate me?
Glucouronyl transferase. Conjugate me with what? With glucouronic acid.
Where the flip does that happen?
In your liver. Now the heme bilirubin will become chole bilirubin, i.e. conjugated bilirubin. The conjugated is direct, while the unconjugated is indirect. After conjugation, of course, you become water soluble, i.e. excretable, which is the whole point because bilirubin is the waste, the bad stuff. Next, this conjugated bilirubin will reach your intestine. The intestine has bacteria. The bacteria will convert the bilirubin into bilinogen. Bilinogen in the urine is uro. Bilinogen, then urobilin, from inactive to active. In the stool, it is stercobilinogen followed by stercobilin, which is responsible for the normal brown color of your stool. If your stool is not brown, we need to talk. Alright, to be exactly sophisticated, this urobilinogen is the same thing that will go to the stool. So in reality, the bacteria of your intestine will only make urobilinogen. This urobilinogen will go to the blood and go to the urine. It will also end up in the stool and will get oxidated on its way to the stool to become stercobilin.
Okay, medicosis, what is the total serum bilirubin?
It's the total bilirubin in your serum.
No kidding. What does that mean?
It's the addition of the unconjugated to the conjugated. So, suppose that your unconjugated bilirubin is 0.3 and your conjugated is 0.2. What's your total serum bilirubin? Well, 0.5. Here is a cool mnemonic for you. There is a Catholic marriage between the conjugated bilirubin and the bile salts. Any patient who has high conjugated bilirubin will have high bile salts. The high conjugated bilirubin will end up in the urine and will make your urine darker, Coca-Cola-like, or tea color. As for the high bile salts, they will make you itch like crazy and they will slow down your heart rate. Bilirubin is waste. Too much bilirubin is bad. It's called jaundice. The definition of jaundice is reminiscent to the definition of cyanosis. What was the definition of cyanosis?
Bluish discoloration of skin and mucous membrane.
Why? Because the reduced hemoglobin exceeded 5 grams per deciliter. Alright, what's the definition of jaundice then? Not blue, but yellow. Yellowish discoloration of skin and mucous membrane and the sclera due to increased serum total bilirubin above 2 milligrams per deciliter. Normally, your total serum bilirubin should hover around 0.5 milligrams per deciliter. It's acceptable all the way up to 1.3. But once you exceed 2, not good. Let me give you an example. Suppose that the total serum bilirubin in a patient is 5 milligrams per deciliter. The conjugated bilirubin is about 4 milligrams per deciliter. Now I have 2 questions for you. Number 1, how much is the unconjugated bilirubin in the serum? Number 2, do you think this patient's problem is too much unconjugated or too much conjugated bilirubin? Let's answer both questions. How much is the unconjugated? This is simple math. 5 minus 4 equals 1. Okay, so the unconjugated went up a little, but the conjugated went up too much. So this patient's problem is due to increased conjugated bilirubin. Let's name it and claim it. You can call this conjugated hyperbilirubinemia or direct hyperbilirubinemia, which means too much bilirubin in the blood.
What kind of bilirubin?
Conjugated or direct.
But what if the patient's problem is too much unconjugated? What would you call it?
Unconjugated hyperbilirubinemia or indirect hyperbilirubinemia. Next, a brief discussion of jaundice. Jaundice has 3 types. Either a problem before the liver, prehepatic, a problem after the liver, posthepatic, or a problem in the freaking liver, hepatic. Each one has another name. Prehepatic, well, it's the red blood cells' fault. Too much destruction. Hemolytic jaundice. If it's after the liver, well, it has to be obstruction. We call this obstructive jaundice. How about if the problem is in the liver? Well, it's a problem in the liver cell, hepatocellular. If the problem is before the liver, i.e. too much red blood cell destruction, who do you think will be elevated? The unconjugated bilirubin, because we are before the liver. Okay, but what if the problem is after the liver? Who do you think will be high in the serum? The conjugated bilirubin, because the liver has already conjugated it. If we have obstruction here, what do you think is going to happen? The stuff will pile up. What do you mean by the stuff? The bile salts and the conjugated bilirubin. And they will be unable to exit. They will be unable to reach the duodenum. Therefore, they have to leak somewhere else, i.e. to the bloodstream. And this patient will have elevated conjugated bilirubin, i.e. Coca-Cola urine, and will have elevated bile salts, i.e. itching and bradycardia. This is how you become a good clinician, not a doofus with a stethoscope. The former patient usually has a history of hemolytic anemia, could be sickle cell disease, could be thalassemia, could be autoimmune hemolytic anemia, could be drug-induced, etc. The latter patient will have an obstruction, could be a stone in the common bile duct called cholelithiasis. It could be obstruction and infection, ascending cholangitis. Could be a congenital anomaly where the bile ducts are very narrow, stenosis of the bile duct, biliary stenosis. Or could be that the bile ducts are fused together and never opened, biliary atresia. Or could be that I have a big cancer in the head of the pancreas obstructing the common bile duct. This is called carcinoma of the head of the pancreas.
How about the patient where the problem is inside the liver?
It's hepatocellular. This liver is toast. It has difficulty conjugating the bilirubin. So the unconjugated will increase because it's piling up before the liver. Even in the fortunate circumstance where you have some functioning liver cells able to conjugate, you are still unable to excrete them because in cirrhosis, the liver is fibrosed. It cannot excrete stuff. So the conjugated bilirubin will have to leak to the blood. So both will be elevated. In a nutshell, in hemolytic jaundice, the unconjugated is high. In posthepatic obstructive jaundice, the conjugated is high. In hepatocellular jaundice, both are high. Let's compare between the prehepatic and the posthepatic jaundice. Prehepatic, what's the problem? Hemolytic anemia could be sickle cell, could be thalassemia, could be drug-induced, could be autoimmune hemolytic anemia, etc.
How about the posthepatic?
Well, we have obstruction. It's cholestasis, slow, stagnant bile. The problem could be inside the liver, such as cirrhosis, or outside the liver, such as strictures, obstructions, stones, cancer at the head of the pancreas, etc. In hemolytic anemia, the unconjugated is very high. Conjugated, a little high, because the liver is trying its best to keep up with the demand. As for obstructive jaundice, the conjugated is very high. Remember the Catholic marriage between the conjugated and the bile salts. Anytime the conjugated is super high, bile salts will be super high. That's why the patient is having itching and bradycardia here, but not here. If you have too much conjugated bilirubin, your urine will be Coca-Cola colored. But since you have an obstruction, this conjugated bilirubin will not make it to the stool. That's why your stool is very pale, because there is less stercobilin in it, because you had less urobilin, because the bilirubin did not get to meet with the bacteria in your gut. But in hemolytic jaundice, when you have too much blood, too much hemolysis, you can get dark stool, yet a normal urine. Do you remember patients with upper gastrointestinal bleed? What do they have? Melena, black stool. So in hemolytic jaundice, the stool is black, the urine is normal. In obstructive jaundice, the stool is very pale and the urine is very dark. Serum LDH is an indicator of hemolysis. It's going to be high in hemolytic, normal in obstructive. Serum haptoglobin consumption is a sign of hemolysis. That's why serum haptoglobin is low in hemolytic, normal in obstructive. Splenomegaly could be the cause of hemolytic anemia because when the spleen gets super big, the splenic macrophages are super active and they destroy all kinds of red blood cells. Especially with extravascular hemolysis, please refer to my hematology playlist. So now the mnemonic is getting even better. With obstructive, i.e. cholestatic jaundice, the posthepatic one, you have increased conjugate bilirubin, also known as cholebilirubin, which is cathecally married to bile salts. When this is high, this is high. When conjugated is high, you get Coca-Cola colored urine, and when bile salts are high, you get B with B, bradycardia and itching. A crazy mnemonic is I'm eating itchy coleslaw. Itchy because I have itching. Col because the col bilirubin, i.e. the conjugated, is high. Slow, that's the status of my heart rate. Now let's compare among the three types. We have the prehepatic, the hepatic, and the posthepatic. Let's go. Tell me about the bilirubin in the urine. In hemolytic, it's absent because the liver is functioning, the bile is functioning, there is no obstruction. Therefore, the bacteria in the colon will convert all the bilirubin to bilinogen. You will not see any bilirubin in the urine. You will find urobilinogen, but not bilirubin. How about in hepatocellular and obstructive? Well, the liver is toast or the biliary system is toast. Therefore, the conjugated bilirubin will leak to the blood, especially with obstructive. And the conjugate bilirubin is water soluble and it will show up in the urine because if you are water soluble, the kidney will excrete you. And anytime you have elevated conjugated bilirubin in the urine, you will get Coca-Cola colored urine. When your blood has the conjugated bilirubin, the bile salts will be high and you will get itching and bradycardia. In hemolytic anemia, the stool could be dark. In obstructive jaundice, the stool is very pale. In hepatocellular, it's pale. Stercobilin will make it to the stool, but it might not make it to the stool if there is an obstruction or if there is fibrosis in the liver. Liver function is fine in hemolytic. It's not the liver's fault. In fact, the liver might try to work harder to keep up with the demand for conjugation, that is. In obstructive jaundice, the liver cannot excrete because of the obstruction. In hepatocellular, the liver can neither conjugate nor excrete the bilirubin. Medicosis nuggets of medicine. Why is your urine dark? The answer is because of conjugated, which makes your urine Coca-Cola. Why is your stool pale? Because there is no stercobilin in it. Why is your stool dark? It could be because of there's too much stercobilin or because there is blood or melena. There are many pathologies that can happen and affect bilirubin. Gilbert syndrome with the G, the bilirubin cannot go with the G into the liver, and that's why you will have unconjugated hyperbilirubinemia. Crigler-Najjar, there is a problem with the enzyme, and there will be accumulation of the unconjugated bilirubin. In Dubin-Johnson, you cannot excrete. In Rotor, you cannot excrete, and you will end up piling up more conjugated bilirubin because it will leak to the blood. I have a video on my channel about cholecystitis. Please watch it. Remember that cholecystitis is inflammation of the gallbladder, the cholecyst, because of a stone here in the cystic duct. Do you think cholecystitis will cause jaundice? The answer is no, because this stone in the cystic duct does not obstruct the flow of bile to the intestine. The path is wide open. However, If the stone started to affect the common bile duct, i.e., choledocholythiasis rather than cholecystitis, then of course this will cause obstructive jaundice. If you want to learn more about liver diseases, GI diseases, orthopedic injuries, download my Surgery High Yields course at medicosisperfectionalis.com. Thank you for watching. Please subscribe, hit the bell, and click on the join button. You can support me here or here. Go to my website to download my courses. Be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine makes perfect sense.